Welcome, everyone, and thank you for joining us for our webinar, Treatment Options for Enlarged Prostate with Dr. Micheal Darson. Dr. Darson is a senior physician with Arizona Urology Specialist. He practices in the Scottsdale, Arizona office. He graduated from The Ohio State University, graduated medical school from Wright State School of Medicine in Dayton, Ohio, completed his surgical internship at The Ohio State University Medical, and his urology residency at the Mayo Clinic Graduate School of Medicine in Rochester, Minnesota. His specialties include treatment of enlarged prostate, voiding dysfunction, minimally invasive techniques for male voiding dysfunction. Dr. Darson was also the first physician in Arizona to perform the newest technology, Rezum, and he continues to be the most experienced physician with this treatment. Thank you very much for joining us. Let me please welcome Dr. Micheal Darson.
Good evening, everyone, and thanks for joining me tonight. This is something new for me, so I'm pretty excited to be here and share my thoughts on BPH and some treatment options for you, and look forward to the questions afterwards. We'll start out, what is the prostate and where is it? So it's a walnut-sized gland at the base of the bladder. It surrounds the urethra. In fact, the first part of the urethra is called the prostatic urethra. It's a reproductive organ that helps in sperm transport. And essentially, the prostate grows to a normal adult size in a man in his early 20s and then starts growing again later in life in the 40s and beyond. What can happen to the prostate? It can enlarge. You can have an infection. That's called prostatitis. And that can be either an infection or just sterile inflammation. And there is a difference in that. And then, as everybody has heard of, you can develop prostate cancer that originates in the prostate gland. So an overview of the benign prostate. BPH means that the prostate has grown larger than normal. BPH can lead to bladder outlet obstruction that can cause lower urinary tract symptoms. So importantly, one thing that you're going to hear a couple times in this talk tonight is enlargement of the gland. But one of the take-home messages that I really want people to come away or go away from this talk with is size and symptoms do not correlate. So it doesn't matter how big the prostate is, it matters how much it blocks the bladder. So that's an important concept. BPH's relation to prostate cancer. So first of all, BPH is not prostate cancer, and that's important to conceptualize. BPH does not cause prostate cancer, also very important. BPH symptoms are similar to those of cancer, and really what I want you to think of is that really that's because they can coexist. I mean, when you develop prostate cancer, your entire gland does not change into cancer all at once. So you can have both BPH and prostate cancer simultaneously. And then a comment about PSA. PSA levels alone do not distinguish BPH from prostate cancer. BPH and prostate cancer can cause elevated PSAs. So when you get a report from your doctor that you have an elevated PSA, you don't have to jump to the conclusion that you have prostate cancer. As the prostate enlarges, pressure can be put on the urethra, causing lower urinary tract symptoms. I'd like to slow down a little bit on this slide because this is really an important one that helps kind of conceptualize what the problem is. Don't get caught up in how big the prostate is. It matters how blocked that tube becomes. The bladder is basically a balloon surrounded by muscle. If the bladder is emptying and it sees resistance from a closed tube all the time, it's like any muscle in the body. It's going to get stronger and more hypertrophic. So that's important because that's where the symptoms come from. An enlarged, stronger bladder doesn't want to store urine. It wants to empty. So men will get things like urgency, frequency, getting up at night. As this progresses, then men will see more of the obstructive symptoms like trouble getting your stream started, weak stream, intermittent stream, dribbling at the end, and ultimately the inability to empty the bladder. And we want to try to intervene before we get to those later stages, because once the bladder isn't emptying well, then it will start to dilate, and sometimes it will lose function, and that can be hard to reverse. So again, that second point is one I've already mentioned. Prostate size does not correlate with the degree of obstruction or the severity of symptoms. Again, that's a big take-home message tonight. I kind of jumped the gun on this one a little bit. We just talked about the symptoms and kind of why you get them. So you get frequency, you get that sudden urge to urinate, you can get a weak stream, not emptying, you notice flow issues or the inability to start your urine. Occasionally you'll see burning. I hear burning from a patient. The first thing I want to rule out is some kind of infection. either a urinary tract infection or a prostate infection. And that's very important to not only identify, but to treat before you really evaluate BPH symptoms. BPH can affect the quality of life. Many men who suffer from BPH experience a reduction in the quality of life. You can see these numbers here. Up to 95% of men with moderate symptoms are unhappy with the way they currently are, and they don't want to spend the rest of their life like that. Most of the time, those are the folks that I'm seeing in my office. Additionally, 51% of men say BPH interferes with an aspect of their normal life. If you're getting up 2, 3, 4 times a night and you're not getting a good night's rest, that's gonna affect your next day. I see a lot of that. 49% of men experience sexual problems associated with LUTS, and that's an important one because a lot of the treatments can affect sexual performance. But one thing that I really like to make patients understand is BPH and erectile dysfunction are not necessarily directly linked, but what happens is the reason they're associated together is they tend to show up in the same patient population around the same age. It's very common to hear both of those, both BPH and erectile dysfunction problems in the same consultation. And BPH also affects everyday life. So who can get BPH? The older you get, the more likely you are to be affected by symptoms. 50% of men by age 60 and almost all men by age 85 are affected by it. In 2010, as many as 14 million men in the US had lower urinary tract symptoms. And obesity and higher body mass index and lack of exercise may increase the risk of BPH. So how is the enlarged prostate diagnosed? Medical history is important. You want to take the time. And what I really like to do is identify what the most bothersome symptoms are. You want to do a prostate exam, a digital rectal exam, and urinary output testing is important. There's a non-invasive way to do that with a uroflow. I think that a more accurate way to diagnose it is with urodynamics. So I utilize a test called urodynamics a lot because that helps me correctly diagnose the patient, and it gives me an idea of where in the spectrum of symptoms that they are. And it also helps me pick out the correct treatment plan for them, and also helps me predict somewhat how I think that they'll do from it. There's self-evaluation of symptoms. There's the American Urologic Association Symptom Index. There's the International Prostate Symptom Score. There are quality of life questionnaires and the Bladder Impact Index. So treatment options. So the first line or less invasive is behavioral modification. And that includes changes in both diet and fluid intake, watchful waiting. So just seeing how you do. And there is going to be some waxing and waning to symptoms. That you may go several months and see some improvement. And then you'll go several months and they say, well, I do remember getting up and now I'm starting to get up again at night. And then you can do Kegels and some bladder retraining. These are somewhat helpful. If you're really good at Kegels, for instance, you can actually practice some urge suppression. There are the first line therapies, which are next. There are BPH medications, which we'll go over those in a moment. And then the two minimally invasive techniques out there are the Rezum water vapor therapy, which we'll talk about tonight. And then there's permanent prostate implants. Then going down the spectrum a little bit more towards more invasive, there's a green light laser procedure. There's the traditional TURP, which is basically carving out the prostate from the inside. And then there's prostatectomy, it's actually called a suprapubic prostatectomy. And that is probably undoubtedly the most invasive way, which can be done these days laparoscopically with the assistance of a robot, but it's still, it's a major operation for sure. So alternative medication, no dietary supplements, in combination phytotherapeutic agents or non-conventional therapies is recommended for the management of lower urinary tract symptoms secondary to BPH. This includes saw palmetto. I do see a lot of patients with saw palmetto, and if they say that they think it helps, then I don't see any problem with continuing it, but it's not something that I routinely recommend. So watchful waiting may involve lifestyle modifications such as adjusting diet, evening fluid intake, medication use, and exercise patterns. 19% were satisfied with lifestyle changes as a treatment. Potential side effects, symptoms may worsen or remain unchanged. If your prostate continues to grow, you may ultimately start limiting your options. And one thing that is important, and I'll repeat this again when we talk about the medication, prescription medications, is anything short of fixing the problem is more like putting a Band-Aid on the problem. It's not fixing it. So if you decide to do lifestyle management, the problem is still going to be progressing underneath and ultimately becomes harder to change. And that occurs with the medications as well. There's obviously no general anesthesia with watchful waiting. There's no permanent implants, and there's no information on surgical retreatment because that doesn't make any sense. So medications, there are essentially two families of medications. The first one is the alpha blocker family. Many of you have probably heard of Flomax, Uroxetrol. Those are medications that the easiest way to think of how they work is it relaxes the connection between the prostate and the bladder, and also it basically affects the capsule of the prostate and allowing the tube to become a little bit more open. What you typically will see is mild increases in flow, 2 to 3 cc's per second commonly. But again, the tube is not becoming unblocked, so it doesn't fix the problem. 71% of men stop taking their medications within a year. Some of the potential side effects, drop in blood pressure, dizziness, fainting, and fatigue. There's some interactions with other drugs. One of the more common complaints I get is, in addition to the dizziness, is a nasal congestion that I try to warn people about. There is no general anesthesia with alpha blockers. There are no permanent implants. And again, there's no retreatment information. The other form or other family of drugs is called the 5-alpha reductase inhibitors. I am not a fan of this drug class. What they do basically is shrink the size of the prostate. But if you remember, one of the very first things that we talked about is size and symptoms do not correlate. Okay, so it doesn't make a lot of sense to me to try to reduce the size of the prostate if it's not going to unblock the tube. And there are some significant potential side effects with this drug class. It predictably lowers the PSA by 50%. So you just have to make sure that everyone's aware that you're on the medication when they're interpreting a PSA. There are definite cases of erectile dysfunction, lowered sexual drive, and retrograde ejaculation. And retrograde ejaculation is also common with the alpha blocker family as well. And there are emerging reports of something called finasteride syndrome, where once you stop taking this drug, some of the side effects don't necessarily reverse. So that's an important thing to understand if you're going to start taking these drugs. There's no general anesthesia with this, no permanent implants, and again, no surgical retreatment information. Let's go to the first minimally invasive procedure, Rezum water vapor therapy. Well, what is it? It's non-surgical outpatient therapy that uses natural energy stored in water vapor to shrink excess prostate tissue. This technology is fascinating because it really does. It unlocks the power of steam to do the work that happens when the steam basically transforms back into water. There's a release of energy. So it works by a dual mechanism. Anything that the steam touches, it's going to obviously affect. Plus, that release of energy is very important and does a lot of work in obtaining the ultimate final result. Some of the potential side effects, there's some pain afterwards with urination occasionally. People will see blood in the urine. People can see blood in the semen. And one thing that I really try to make patients understand is urgency, frequency, and potentially getting up at night may get worse before it gets better, okay? And I really try to impress upon patients that you really need to be patient with these minimally invasive procedures like Rezum because there's a trade-off. It's a very safe procedure and it's very effective. But the trade-off is you don't get immediate satisfaction with it. So there's not immediate gratification. And I tell patients that they really need to be patient for about 4 to 6 weeks. And then they really start to improve. And I think you can predictably say that people will improve up to 6 to 8 months after the procedure. But in my practice, I've actually seen patients improve up to a year after. And then they reach their new plateau and their new normal. General anesthesia is not used for this. It's office-based. We typically just use local anesthesia, plus or minus some oral sedation at times. There is no permanent implant with Rezum, and there is a very low surgical retreatment rate. I mean, 4.4% at 5 years is a very low retreatment rate, as you'll see as we talk about some of the other options. So that's basically the delivery device, and you can see that there's going to be a little needle that comes out, and it has fenestrations or little holes in it. And over 9 seconds, that will pulse steam into the prostate, creating a vapor cloud. So anything that the steam touches, it's going to destroy. But also that, as I said, that release of energy is important as well, because that will permeate out a little farther than the actual treatment zone. And as the video is depicting, what you're trying to do is create contiguous vapor clouds. And then those treatment areas will reduce in size by 50%. So the next treatment option would be prostatic urethral lift. What is it? It's a non-surgical outpatient procedure that utilizes permanent implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. Potential side effects: some pain or discomfort when urinating, blood in the urine, pelvic pain, urinary stones. The stones can form if the implant is placed on the intravesical or inside of the bladder portion, and it's exposed to urine. A stone can form on there. And then urinary frequency and incontinence can be seen. There typically is not a general anesthetic. There is a permanent implant. Data suggests that there's a 13.6 surgical retreatment rate at 5 years. So a green light laser, what is it? It's a surgical outpatient procedure that uses a laser to vaporize away the prostate tissue. So basically you're utilizing laser energy and you're vaporizing the tissue. And that's in an effort to vaporize enough tissue that you can then open up the tube. Some of the potential side effects of this is pain or discomfort when urinating, blood in the urine, urinary retention, urinary tract infection, and urgency frequency. A laser is a very powerful source of energy, and with that increased power comes the potential for some irritative symptoms that be bothersome in the short term. It does require a general anesthetic. There is no permanent implant, and it has a very low surgical retreatment rate of 4.8% at 5 years. And here's a short video. And you can see the green laser, hence the green light laser name. And you'll basically go in with the instrument into the prostatic urethra. Identify some landmarks that you want to make sure that you don't use the laser in. And basically you fire the laser, and with that kind of back and forth motion, and you can actually see the tissue vaporizing away as you go. The next surgical treatment option would be a traditional TURP, a transurethral resection of the prostate. What is it? It's a surgical outpatient procedure that uses a heated wire to cut tissue from the prostate. A more common, more modern one would be using a bipolar plasma kinetic field, which is essentially just another energy source. And you basically carve the prostate out from the inside. So instead of vaporizing it like the green light laser, what you're actually doing is carving out the prostate, and you actually get tissue that you remove from the bladder when you're done. And the advantage of a TURP is it's got a very good track record. It's the historical gold standard. The tissue can be analyzed for prostate cancer, and sometimes we detect prostate cancer when we do a TURP that hadn't been otherwise diagnosed. You don't have tissue when you're using a green light because the tissue is being vaporized. The potential side effects, some pain or discomfort when urinating, blood in the urine, urinary tract infection, and urinary retention, which is where you can't go to the bathroom. There is a general anesthetic. There is not a permanent implant. And again, a very acceptable low retreatment rate of 5.8% at 5 years. And then there's prostatectomy. Historically, a suprapubic prostatectomy was done through a midline incision in the lower abdomen. Basically, you go down, open up the bladder, and then you shell out the prostate, kind of like putting your finger underneath the skin of an apple and just working your way back and forth until you basically enucleate enucleate or remove the pulp of the apple, leaving the shell there. In today's world, we can do that laparoscopically with the assistance of a robot, but the procedure is much like I just described, where you're basically removing the prostate, leaving just the shell of it. One of the bigger side effects of that is definitely there's a higher risk for bleeding, especially in the traditional open way. Blood transfusions are sometimes needed. Sepsis, which is a life-threatening infection, can occur. And there's basically 100% retrograde ejaculation rate with a prostatectomy. And there's a very high retrograde ejaculation rate with a properly done TURP as well. It does require general anesthetic. You'll probably at least spend one night in the hospital. There's no permanent implant, but there is a very low retreatment rate of 2.7 at 5 years. Insurance coverage, it is a responsibility of the patient to contact their insurance provider for specific coverage information, but most or all of these that we've talked about should be covered by insurances. And to do a brief summary, we've talked about the prostate, we've talked about what happens or how it works, we've talked a lot about BPH, the treatment options, watchful waiting, first-line therapies or medical therapy, Rezum, water vapor therapy, or permanent implants, and then the more aggressive or invasive surgical procedures such as green light laser, traditional TURP, and a prostatectomy. Next steps, consultation with your urologist is required to determine which therapy is the best treatment for you.
Dr. Darson, first question is, if BPH and cancer can exist simultaneously, is a prostate biopsy necessary prior to treatment for either type of treatment?
Good question. So the only way to diagnose prostate cancer is basically a biopsy. Now, I did mention a TURP. Sometimes we uncover cancer that way, but the most common way to diagnose prostate cancer is a biopsy. You have to have tissue for the pathologist to look at under the microscope to diagnose prostate cancer. A prostate biopsy is not required, though, for treatment for BPH. Basically, if you're having symptoms of BPH, you're going to get a rectal exam. That's part of the workup for it. But if your PSA is normal and your rectal exam is normal, you don't need a biopsy to pursue treatment for BPH.
What does retrograde ejaculation rate mean? Please explain.
So retrograde ejaculation is, normally when you ejaculate, the ejaculate comes out of the penis in what we call an antegrade fashion. So retrograde ejaculation is when the ejaculate does not go out of the penis, it actually goes back into the bladder. It's really not a medical issue. It's more, obviously it's a quality of life issue, and obviously it's a fertility issue. So, if you're still interested in having children, you definitely want to pick the right treatment option that has the lowest retrograde ejaculation rate.
Can you explain what a urolift procedure is?
Yeah, so that's what we talked about, the prostate lift. It's basically you put in a device that kind of pinches the prostate and holds it out of the way. Those implants are permanent. Think of it as pinching the prostate in an effort to open up the prostate to relieve symptoms.
If you do the Rezum treatment, how long does the procedure take, and what is the recovery period?
The amount of time that it takes to do the procedure is prostate size dependent, okay? So what I tell patients is roughly there's one treatment for every 10 grams of tissue, and this is a rough estimate, because it also depends a lot on prostate anatomy. And that's the real beauty of Rezum, is you can tailor that Rezum treatment to every guy's prostate, and everybody has different anatomy, and so therefore it's a huge advantage to be able to tailor the treatment to that individual. If you have, say, an 80-gram prostate, you're looking at roughly 8 treatments areas. That's roughly going to be 8 times 9 seconds, which is 72 seconds. So the treatment times are quick. Recovery is also quick from these procedures, and that's one of the reasons that these minimally invasive procedures have gained such popularity so quickly, because patients can get back to their normal activity very quickly.
Is a catheter needed after the Rezum treatment?
So that's a great question. And here is the current state of my practice. So what I found is when I first started doing Rezums, I didn't catheterize people. But what I found was roughly 50% of those folks were going to go into retention either that night or the night or two after the procedure. Even with urodynamics, it is very difficult to predict who is going to go into retention. What I offer patients is either let's put a catheter in, or we can teach you how to do intermittent catheterization. So if you are one of those patients that go into retention after the procedure, you can actually put the catheter in, let the urine out, and then take the catheter right back out. And that you might only have to do that once, or you may have to do that over the course of several days.
Can you explain what retention means, please?
Oh, yes. So urinary retention is where you cannot go to the bathroom. So you have the urge like you normally would, but then you can't go, you can't initiate your stream. And if that happens because of swelling from the prostate from a procedure, then the bladder, your body is still going to produce urine. So the bladder is just going to fill and fill even more. And that becomes pretty painful.
Is the tuna surgery still in use?
Tuna is not currently part of the AUA guidelines to offer as a treatment option. Over the course of my career, I did hundreds of tunas and got actually really good results with it. Having said that, what I would encourage people to think of is Rezum is kind of the next step in technology. So it's the next generation, basically.
Is Rezum effective for any size prostate?
Most of the science or studies look at prostates between 30 and 80 grams, okay? Our institution in our office was one of 10 sites nationwide that was actually accruing patients looking at prostates that were even bigger than 80 grams, and specifically between 80 grams and 150 grams. Now, I can tell you that my real world experience, I have done plenty of very large prostates up to 260 grams, which is a pretty rare but very big prostate. And I did that in an elderly gentleman who was in urinary retention and who was such a poor health risk that no other urologist would do a procedure on him because they were scared to give him anesthesia. And really nobody had very much experience with doing Rezums with big prostates. And after a couple discussions with this gentleman, I did his Rezum, and within a month he was urinating. And talk about a great success story. That was really a life changer for this very elderly gentleman.
This question is from an 86-year-old man. He's asking, are there any health problems during the Rezum process that would exclude you from being able to have Rezum? And what about the recovery for an older person?
Well, it's a well-timed question because the gentleman that I was just talking about a moment ago was actually 92. Age is not a restriction. And actually, if you do have some debilitating other health issues that may put you at even higher risk for a general anesthetic, then yes, you're actually going to be a better candidate for something where you're not getting a general anesthesia and the inherent risks that go with that. So no, just because you may have other health issues does not mean that you can't or shouldn't pursue a Rezum minimally invasive procedure that is ideal for you.
Are the Rezum treatments done one right after the other on the same day?
Yeah, they're all done in the same setting. So for instance, if you're going to get 8 treatments, they're all done same day, same setting, same local anesthetic.
And where is the Rezum procedure done? Is it done in the office, and what type of anesthesia?
So it's an office-based procedure. We use a combination of local anesthesia. So there's intraurethral lidocaine. So basically it's a lidocaine gel that we squirt down the urethra, okay? And then we use an ultrasound probe rectally, and that ultrasound guides us to allowing us to place lidocaine. And the way I describe it to patients is what we do is we basically put a cradle of lidocaine around the prostate, and then we let that sit there for about 10 minutes and let that diffuse out so it can affect as many nerves as possible. And then I come in and do the procedure. And during the procedure, what I tell folks is they're going to probably feel some warmth, some heat, either rectally or in the penis. Typically, people tolerate it fine. The bigger prostates that require more energy, the device does heat up a little bit. So there's a constant flow of cooler saline or sterile water that we put in to cool the urethra down. So you've got a local anesthetic rectally, you've got some intraurethral lidocaine, and you've got cooling water that's actually flowing through the urethra to keep the urethra cool while the steam's going in.
The patient wanted to be put to sleep for Rezum. Is that possible?
Well, it's certainly possible. I mean, we don't put people to sleep in the office. Rezum is not done in traditional operating rooms. It can be done in a surgical center. For instance, I'm doing one next week on a gentleman who really wants to be put to sleep. And so we'll go ahead and do him in the surgery center, do him under the sedation or anesthesia that's safe for him. And I will say that one thing is that I'm actually looking forward to and hoping for is utilization of nitrous in the office. Much like you patients that have ever had it probably had it with the dentist. I'm hoping that we can start doing that in the office, and I think that will help ease those concerns from patients that may be reluctant to get the procedure done or even the workup for it, because listen, everybody's got a different pain tolerance, and we want to make the experience as good as we can.
That brings us to the end of our questions. Dr. Darson, would you like to wrap up for the evening?
To everybody that's out there, please feel free to reach out to me. I'm happy to see you as a patient, answer any questions.
Thank you, Dr. Darson, and thank you everyone for joining us this evening. Dr. Darson practices in the Arizona Urology Specialist office in Scottsdale. You can get more information or make an appointment for one of our 9 offices or telehealth by visiting us at www.arizonaurologyspecialist.com. Thank you again for joining us. We wish you all good health.